We're about 5 minutes running into it. Today, the topic is how to tame the monster within. Anybody in here never had a stomach ache or a upset tummy? Do we have anybody at all? Okay. I think this is a very common problem, and we're not really going to talk about the cancers or the really bad things that go on in your stomach, but I think everybody's just been inconvenienced by your stomach, and Dr. Lynn's going to talk about when you need to take your indigestion or your diarrhea or your constipation or your bad stomach ache seriously and not just over the counter. Our party favors today are antacids, and that seems to be appropriate because when I get the reports from Blue Cross Blue Shield and Cigna, guess what's one of the most commonly prescribed drugs that city employees are taking? I think it beats out everything, Nexium. Believe it or not, we have a lot of people on prescription Nexium. Dr. Dawn Lynn, this is her, I believe, her third time to come and talk to us. We really appreciate that she's here and able to come talk to us. And she's an osteopathic doctor, and she's got her degree from the West Virginia School of Osteopathic Medicine, graduate studies at the University of Tennessee in human performance and sports studies. She specializes in the body as a whole. Osteopathic physicians view the body as an interconnected system, and they receive specialized training in the musculoskeletal system, and she has an office here in Hendersonville. So thank you very much for coming.
All right. So I'm just going to a little disclosure here. I'm a family medicine physician, so I am not a gastroenterologist. Say that 5 times fast. Gastroenterologists are the specialists who deal with what y'all know as GI or belly docs. We have a plethora of them here in Sumner County, some great ones. So I'm going to speak on some common things that most of you will go to your family doc first for, and you might get referred to a gastroenterologist or not. So just so that's disclosure, we're hitting the surface. I did pass out a sheet here, diseases of the digestive system. The digestive system runs from the mouth all the way down to the other hole. So from the top to the bottom, that is where the digestive system is. So you can see why a gastroenterologist is needed as a specialty. They deal with everything from top to bottom. So it's not just a matter of the stomach, which is what everybody thinks of when they think gastrointestinal, the stomach. And in fact, your stomach actually causes less problems than the other organs that are in the GI tract. It's just that we call it the belly or the stomach because that's where it's all contained near. So this picture, it just has a few of the points at the organs, and the picture that I gave you just talks about common conditions. So if you see, not common, but just diseases. So we are not going to talk about all of these diseases today. It's much more than we could ever have time for in one day anyway. So basically there's many organs involved. It is very complex. You cannot have one part of the GI tract without other parts getting involved. And it actually has its own chemical and neurotransmitters in the GI tract that are similar to the brain. So the brain has its own little system. The GI tract also has its own little system. So there's a lot of connectivities between the brain and the GI tract that if you have brain things going on with the sensitivities in your brain, chemicals that are off in your brain, it actually does affect the GI system directly. So it's an interesting little system that is not little at all and takes up everything from, like I said, top to bottom, right below the heart and lungs. So we'll just jump right in. Esophageal reflux, as some people call it, acid or heartburn or just burning in the chest. The interesting thing about esophageal reflux, it's not defined the same by every person. So your symptoms may be different from your symptoms, may be different from your symptoms. As Kay talked about, Nexium. Nexium is one of the older PPIs, or known as proton pump inhibitors. It's an acid reducer, basically. They got popular. If you read the box of Nexium that you buy over the counter, it says do not take for more than 14 days. How many people take it every day for the last 20 years? They've been taking it for a long time. So the reason they say that is because, again, if you have issues and they're not resolving with simple over-the-counter techniques that can be great, there may be something else going on that needs to be evaluated. So most commonly it's caused by backup of food into the esophagus. The esophagus is the swallow tube. The swallow tube works while you eat, you swallow, and it does its own thing. You don't actually swallow. Once you get it past your mouth, the swallow tube does the work for you. It's a muscle. It works. It swallows down itself. You don't do anything to make it happen. So if the food gets down, there's a little sphincter that keeps it from getting out of the stomach. Once it gets in the stomach, that little door closes, it keeps it in the stomach, and then the digestive system starts to churn, and all the juices come in, and all the other organs get involved. So esophageal reflux is when some of that food or some of the acid that's breaking up that food actually splashes back up into your swallow tube. So that's where that burning sensation comes from, that chest pain comes from. Some people's little door doesn't close all the way. Some people overeat. I don't know anybody who would, but some people do. And then some people there's a lot of other reasons for it. So it can cause central chest pain, a burning sensation, nausea, abdominal pain. It can actually be back pain, left wall pain. So it does mimic the signs of a heart attack in a lot of people. And so some people say, they will come. I have literally seen people in the emergency room thinking they're having a heart attack, and it is severe reflux. We never want you to think, oh, it's just severe reflux, and not go to the ER. So we do not mind you coming in if you think you're having a heart attack, because there have also been people who said, oh, I just thought it was severe reflux, and it was a heart attack. So they can mimic each other because the heart and the stomach literally lie right next to each other. And so the pain in one goes to the same areas as the pain in the other. So if you're having symptoms like that, definitely get it checked. Now, simple burning, people will take Tums, like we've passed out, the antacids, Rolaids, any of those sorts of things. They can help calm it down. They're calming down the acid. As somebody mentioned before we started, when I swallow, it goes down and it kind of gets stuck in there. That's a whole nother problem. That is acid reflux, but it's worse than, it's not just daily acid reflux. That can be a whole nother issue. So dysphagia is the fancy word for the food getting stuck. Dry cough, lump in the throat. Be surprised when people come in and say, I've been coughing, I can't stop coughing, I can't stop coughing. It may actually be acid reflux causing you to cough. So there's lots of things that acid reflux portrays itself as. You definitely need to see a doctor when you're taking medications for this, or you're having to take them every few hours and it's not going away. At least twice a week, or if it's interrupting your daily life, then this is something that you and your doctor need to discuss. If it causes severe chest pain or pressure, that could be signs of heart trouble, not just reflux. And if it causes you to spit up blood or to vomit consistently, that needs to be checked. Why is it dangerous? If it's just acid, it's just a little reflux, a little heartburn. But what happens is that acid comes back into the swallow tube, and it actually changes the structure, the columnar structure of the cells. They go from being nice little shape, and then they change structure. Anytime the body changes the structure of its cell, it leads to a worsening disease. That's where cancer comes from. So we are going to hit on touches of cancer, but we're not going to focus on it. So we don't want that continuous acid or reflux to change the shape of your cells to potentially lead to cancer. And so most people, when they do their colonoscopies today, are also getting upper endoscopies or EGDs, or basically the tube down the throat. And that's because the GI doc wants to look and make sure that, because that acid is not changing the cellular structure of your esophagus, because that can lead to throat cancer. So ways to reduce your risk. You're going to see in most GI problems that we talk about today, carrying extra weight is one of the biggest causes of most of the gastrointestinal problems. So keeping your weight in a good place. Smoking is a huge risk for esophagitis. Don't overeat. Keeping your asthma and diabetes under control actually plays into it, again, because of the little chemical imbalances that we were talking about. You don't want to eat too close to bedtime, because then you're laying down and then it just flushes back up due to gravity. You want to elevate the head of your bed. Sometimes that can help people from laying down flat and they get that acid washed back up. And then tight clothing can actually restrict your ability to digest well and for the food to move through. So there's a lot of things you can try for that. A lot of medications, definitely something to discuss if you're having issues with. We're going down the body a little bit in some of my discussions. So the next, underneath the swallow tube, you'll see is the stomach. That is the stomach. And a peptic ulcer, people say, oh, I have ulcers, or you'll hear people say, I've had a hole in my stomach. An ulcer can be in lots of different places. It can be in the top of the stomach, in the body of the stomach. It can actually move into the small intestine. Ulcers are little open sores, just like you would think of on the outside of the body. You can get one on the inside of the body. And acid reflux can actually lead to an ulcer if you have an extra production of that acid that just eats away at the stomach lining and it causes a sore. That is not caused by spicy foods or stress. People, I'm stressing myself into an ulcer. To a degree. That comes with a caveat that there are, like I said, chemicals in the stomach that are similar to chemicals in the brain. If you have a lot of stress, your body reacts with a lot of stress. So excessive stress in your life leads to excessive stomach production at times, and that's where the ulcer comes from. So it is a direct correlation with the actual acid in the stomach. So it's not just the stress. There's actually more that goes into it than that. A peptic ulcer, you say, well, how do I know the difference between the burning from the reflux and the burning from an ulcer? Usually, reflux comes after you eat, you've had food. An ulcer is when you're hungry. You're hungry, your stomach starts to growl, but it is burning and gnawing. You've got that gnawing sensation, and it hurts. It's not just, oh, I'm super hungry. It really is. And then if you eat something, that burning calms down or that gnawing calms down. That's when you might be more concerned that you have an ulcer. It can be intermittent. You may not get it with every time. But if you notice, man, when I'm hungry, I just feel like I have to eat to get my stomach to calm down, that might be the signs of an ulcer. If you start spitting up blood or you had acid reflux and any blood comes out, and I'll just stop here and say, if you got blood coming out of any orifice, it's not right. Okay? Blood should not come out of the body. It should stay in. So these are signs when you need to get it checked. If dark blood in your stools or black stools, that can be a sign that you're having an internal bleed. So those need to be checked. Sorry, we're talking about stools at lunch. It's not my idea, okay? When you're hungry, like I said, if you get really nauseous when you're hungry and then when you feel the need to eat to calm it down, that can really be a sign. If your appetite just changes and you say, I can't eat like I could, or things have just all of a sudden, I'm not able to eat as much, or I feel like I have to eat more. And an unexplained weight loss, of course, is always a sign. So again, avoiding too many NSAIDs. NSAIDs are anti-inflammatories. They've been all over the news in the last couple of years. They cause a lot of issues if you take chronically. If you take them every once in a while, intermittently, you should not have problems. But chronic use of ibuprofen, Advil, naproxen, Aleve, Mobic, Celebrex, there's lots of them to talk about with your physician. But taking too many of those, actually, they sit in the stomach is the problem, and they can actually eat away at the stomach lining too. Again, don't smoke, that says don't drink alcohol. Drink alcohol responsibly and intermittently. Avoid the overuse of antibiotics. It's a whole other conversation worth having, but antibiotics are rarely actually needed in our society, but we like to use them like candy. But overusing antibiotics kills the natural antibiotics that are in our system, and that causes, again, more acid production and more problems. And avoiding contact with H. pylori, like you would know that, but H. pylori is a bug that, not a physical bug, sorry, medical term, a bacteria that can cause ulcers. So if you have continuous, your doctor's tried to treat it, nobody's not getting anywhere. H. pylori actually can be found in blood tests, simple blood tests. But if your spouse has it and you don't know, it actually can be shared by physical contact. So H. pylori is pretty easy to spread, and it's also pretty easy to treat with antibiotics appropriately. So that may be something that you'd have to talk to your physician if you're having continuation of this. Continuing on down past the stomach, we're skipping over where the stomach comes next to, right under the liver. The liver is the giant organ on top. We're not even discussing the liver today, but the gallbladder is right underneath the liver. It's a little tiny, pear-shaped, ugly green organ that we're actually not sure why we have now. There's a lot of theory behind it, but it does participate in digestion to a degree, but we do know you can live without it, as I'm sure many of you can attest. The gallbladder, as it says, 22 million people are affected by gallstones or gallbladder disorders. Gallstones form when you have too much cholesterol, not having heart talk, but too much cholesterol or too much waste, as in body waste, gathers in that area, and it forms into little stones, just like you would anything that sits in one area and churns and churns and churns, turns it into a stone. Or the gallbladder just doesn't function as well as it should. Its job when you eat, it contracts and it dispenses some digestive juices, and it helps you to break down your food. And if it doesn't contract very well, then all those digestive juices hang out in there and they don't get emptied well, so it forms stones. So a lot of people have stones and don't know it, but it can cause abdominal pain. A big sign of it is people say, every time after I eat, I get so sick and hurt right here. It's usually in the right upper quadrant, the right side. You can actually get right shoulder pain, and that's the biggest symptom people have. They come in, but I've literally seen people come in and they have central pain, they have central back pain, and it doesn't have to be after you eat, but that's just the most common. It can cause a blockage, actually. If you get one of those little stones and it gets squeezed and it gets squeezed out, there are little tubes that it has to go through. The digestive juices are not very big. So you can actually get blockages in your liver, in your pancreas, and so they can cause a lot further damage if we're not careful. So paying attention to these aches and pains is important. So the warning signs: abdominal pain after eating. If every time you eat you're nauseated, you're vomiting, you can't keep things down. If you get pain between your shoulder blades, again, your right posterior shoulder, these are things that, hey, maybe my gallbladder's trying to act up on me. There are ways to, again, reduce your risk by watching your diet, watch your weight, keeping your weight down, because the old adage for gallbladders is fat, 40, female, and fertile. So women in their 40s typically who carry extra weight are more likely to have gallbladder disease, but it hits men and women both. So you want to eat a low-fat diet because, again, the cholesterol, keeping your cholesterol in control, your diabetes in control, those are the things that add into the juices of the gallbladder, and they actually cause the stones. So keeping those things down will reduce your risk for forming stones. And a side note for the gallbladders, you do not have to have stones to have gallbladder disorder. Your gallbladder just may not work very well. So you may not actually have stones, but gallstones are the most dangerous part of the gallbladder if you do form them. Irritable bowel. We don't have enough time for irritable bowel. I'm just going to briefly touch irritable bowel. It is a wide diagnosis. It says that 10 to 15% of the U.S. population is affected, but it really is 1 in 5 adults have the sign or symptoms of it, but they just don't go get it checked out. They just don't go because they say it's no big deal. And I'll just live with it, or I'll just deal with it myself. This is an effect of the large bowel. So this, if you look on your picture, the large bowel is the biggest bowel that makes a loop around the tiny little circles in the middle. So the large bowel is the one that makes all the stool. So that's the one that takes all the food and everything you've eaten that the body wants to get rid of. It's done taking all the nutrients, so it sends it to the large bowel to compact it and get it ready to excrete. So there are 2 types. There's irritable bowel syndrome constipation and irritable bowel syndrome diarrhea. And so the symptoms actually can be shared, which don't make sense to a lot of people. That's why it's a little bit of a complicated diagnosis, because just because you don't have good bowel movements doesn't mean you don't actually have diarrhea, and just because you don't have good bowel movements doesn't mean you have constipation. So this is a discussion worth having with your physician if you're having some of these symptoms. So if you have abdominal pain or cramping after eating, when you need to have a bowel movement, if you're getting an excess of bloating or gas, if you have diarrhea or constipation in general, and we're going to define that, or if you have mucus in your stool with some of these symptoms, this can be a sign of irritable bowel syndrome. There used to not be as many treatments as there are now for irritable bowel, so this is something that definitely needs to be discussed. There's a lot of good things to do, and there's a lot of terrible over-the-counter options that can actually be detrimental. So you want to see your doctor if you have a persistent change in your bowel habits. This isn't just a simple, I got a bug, and for the last 3 or 4 days I've been having a lot of diarrhea, and it goes back to normal. Obviously, we're happy to see you for those things, but if this has been chronic, going on for 3 months, and things are just not getting back to normal, then this needs to be checked. Pain with bowel movements also, bowel movements should be easy. They should be in, out, and done. And then if you have changes in your weight or eating habits, those need to be discussed. There are a lot of food allergies or intolerances that can lead to irritable bowel. Again, there's so many that we don't have time to discuss that. Stress can actually increase irritable bowel. As I mentioned before, the chemicals in the stomach are similar to those in the brain. So if you experience a lot of stress, a lot of anxiety, depression issues, it can actually come through the stomach and then can portray as irritable bowel. Hormonal changes, and this is not just estrogen, testosterone, but even your hormonal changes, your thyroid changes, those are different types of hormones that can also affect your bowels. So, and viral and bacterial infections can be acute, like I mentioned, but they can lead to longer-term irritable bowel if it does not fix itself. A big red flag is if you have rectal bleeding, abdominal pain that occurs or progresses at night, and weight loss, those are red flags. So people say, oh, I've just got a little bleeding, and just because I was constipated and I'm just losing weight because I'm going to the bathroom all the time, that's a red flag. That is not normal. So we're going to talk about constipation a little bit. Constipation is not necessarily the same as irritable bowel constipation. Although, if you go to most physicians, we're just going to classify it because it's really hard to tell the difference in some ways. What people don't know is you do not have to have a bowel movement every day. Most men will... Oh, you're in trouble, yeah. She probably gave you a lot of things we don't want to know about. Most men will have a bowel movement every day. Many men will go after every meal. That's not abnormal. That's actually pretty normal. Your body's getting rid of the old, taking in the new. It's pretty common. Most women will not have a bowel movement every day. Most women will go 2 to 3 days, if not more. So constipation is defined as fewer than 3 bowel movements in a week. So it doesn't have to be every day. You can tell her I said that, but don't tell her it was me. And if you have very hard stools, if you have to strain to have a bowel movement, or if you need physical help to empty, and that means, pressing on your stomach. Some people, unfortunately, have to use their hands to help get things out, and that happens, and that is constipation. Like I said, bowel movements should not be this difficult. They should be in and out and done and go on with your day. So this really is a problem, but this number, $725 million a year spent on laxatives. I can't even fathom that, but laxatives are terrible. They actually can lead to addiction of the bowel. So the bowel gets used to having that stimulant, gets used to having it, and then goes, hey, I need this. You got to give it to me again. I can't go without it. And so you should never use a laxative for more than 2 to 3 days at a time without discussing it with your physician. Because if you get into that pattern, we're talking about a whole nother complication in issues that can lead to obstruction and maybe even surgical intervention. So if you're having that much difficulty with going to the restroom or feeling like you're not emptying well, this needs to be discussed with your physician further. If you have persistent changes in your bowel habits, pain with bowel movements again, or changes in your weight, and I keep saying the same things over and over, but as I mentioned, the body runs a certain way. It likes to run a certain way. If it gets off habit and things happen, it's just smart to be aware and have a discussion. There are lots of easy things you can do for constipation. Actually, one of the best things you can do is drink water. Most people don't drink enough water. They drink plenty of soda. They don't think Coca-Cola's hurting at all. So you can drink plenty. If you drank as much water as you drink soda or tea, you probably wouldn't have problems with constipation. That's mostly what I do with my patients that come in with constipation. I take and make sure they're drinking 80 ounces of water a day. If you're drinking 4 bottles of water a day, you're probably going to have some pretty good bowel movements. You'd be surprised at what you don't drink if you don't really measure it. So exercise actually stimulates the bowels to move forward. So exercise, if you take a walk and drink all that water, you'd be surprised. You can actually add a little caffeine in the morning, a little coffee, you'll push things through if you need that help. Eating high fiber diet, and then of course keeping your weight down can actually help with constipation. The complications are hemorrhoids, fissures, impaction, rectal prolapse. We're not going to get into all the details of those things, well, except for hemorrhoids in a second, but these are just things that you don't want to deal with, because then if we could have just stopped the constipation, we wouldn't. Some of these are surgical, and so we don't want to even get down that road. You can actually cause nerve damage with constipation, or nerves can be damaged to cause your constipation. So we never want you to look at it as if, oh, it's just my diet, oh, I'm just not having a good bowel habits. You might actually have some nerve damage in that area, or you could have a blockage, whether it be by stool or, God forbid, a mass be blocking you and you can't get the stool out. So those are things you want to look into also. Hemorrhoids. Y'all done eating? Hemorrhoids are, it says by age 50, nearly half of adults have dealt with the signs of a hemorrhoid. So there's some people who have hemorrhoids and don't know it. Hemorrhoids are very, very common. They usually aren't known that you have one until you have symptoms of one. There's 2 types of hemorrhoids. There's an internal hemorrhoid and an external hemorrhoid. Internal hemorrhoids, typically, that's where people will say, when I wipe, I get a little blood on the paper or a little blood in the toilet. That's usually an internal hemorrhoid that when you've had a bowel movement and the stool has pushed past, it is caused to bleed. They're typically not uncomfortable. You just notice it and you start to go, oh my gosh, what is that? And which is what you should do. Again, keep in your head. Dr. Lynn said blood should stay in the body, inside the body. If you're not careful, though, that internal hemorrhoid that is not bothering you at all except for causing a little bleeding can actually come out of the body, and then you have a problem. So it can prolapse outside the body, and then that would be a bigger issue. The external hemorrhoids are typically the ones that they itch and they have a lot of irritation. They get really swollen. Sometimes when you wipe, you feel a little extra swelling down in the bottom. You might feel a little lump down there that's sensitive. They hurt. It's not comfortable to have a bowel movement. So these are ones that actually, if you are not cautious and you are continuing to strain, both of these can actually fill up with even more blood and have to be cut out. So these are things that you need to pay attention to also. So reducing your risk for hemorrhoids don't strain. They are blood vessels. So there are blood vessels on the inside and blood vessels on the outside of the rectum, and that they just get filled up with blood because of straining. So if you can imagine that someone who lifts weights and they're lifting really heavy weights and you see these blood vessels pop out of their chest or their forehead, it's the same thing. These are just straining blood vessels that are popping out of your bottom. If you sit for long periods of time, this says on the toilet, but if you sit for long periods of time, period, in a car, at a desk, at anything you're doing, your risk for hemorrhoids goes way up. So sitting for long periods of time is actually a risk factor because of just the poor positioning. Chronic diarrhea or constipation, because the more bowels that move through, even with diarrhea, the more risk that you're pushing some of those veins through. Obesity or pregnancy, eating a low fiber diet, and of course as we get older we're more likely to have hemorrhoids just because of the laxity in our muscles have allowed for the veins to pop out more. You can get anemia, which is a blood loss. You can have them strangulated. They have to be cut out. And so eat a lot of fiber, drink plenty of water, exercise, don't have bowel movement problems. These are all the same. I'm repeating myself. So we're going to touch on cancer very briefly, only to say this. C is usually for Cookie, but now I think he's Veggie Monster or something weird that they've changed him to. But C right now stands for cancer. So you can have cancer in every single step along the way of the GI tract. Every single step. So all the way from the mouth to the rear and everything in between can have cancer in it. And unfortunately, it is not easy to find cancer of the GI tract. We do not have good ways to find it. That's why the only thing that we really know well is the colonoscopy and the upper endoscopy. So the goal of those is to get into the GI tract from both directions and see what we can see, which is the the stomach, the esophagus, the very beginning of the small intestine, and then almost all of the large intestine. But there's a lot in between that we cannot see, we cannot screen for, we cannot find. There's a lot of cancers we can't find. So you hear, pancreatic cancer is a big scary one because we usually don't catch it till it's way too late. Liver cancer the same way because sometimes there's no signs and symptoms. So these are things that's why it's important to get your physicals, talk to your doctor if you have any changes in any of your habits. This is a poorly able to see slide, but I wanted to point out when you talk about GI diseases and cancers, the number one cancer, let's see, we're going to talk about that one on the next one. So when you talk about GI cancers, colorectal cancer is 142,000 people get it in 2013 and 50,000 deaths. So this is not a small amount of people. But if you'll go down, the pancreatic, liver, stomach, and esophageal cancers are higher as far as how many people we lose to them. Again, we don't have a lot of good methods of finding them, and we don't have a lot of good treatments for some of them either, unfortunately. But the colorectal cancers we can catch, and the esophageal and stomach cancers we're getting much better at catching and stopping and helping. The most important thing you can do is get screened, get in to see people. So everybody knows about October. October is what? Cancer Awareness Month. Right, it's pink. Everybody wears pink. If you really want to know where breast cancer falls into the list of cancer deaths, it's actually lower than colorectal cancer. So more people die annually of stomach cancer or colorectal cancer than they do of breast cancer. So breast cancer, I think, is 4 or 5 on the list of cancer deaths, but they are marketing geniuses. They get more money than any other cancer because they've geniusly done that. It's important. I'm not saying it's not an important cancer, but lung cancer being the deadliest cancer gets only maybe a quarter or a third of the funding that breast cancer does. And stomach and colorectal cancer get hardly any when it comes to comparing the amount of money that's raised for cancer awareness. So stomach cancer, more people die of stomach cancer every year, and more people die of colorectal cancer every year than they do of breast cancer. So these are things that mostly because people just get these symptoms that we've talked about and don't go get checked. They don't get it checked. Esophageal is right below breast cancer, and esophageal is one of the fastest growing cancers. So this heartburn that we're talking about, this acid, is the changing of the cells is actually causing an increase in it. So just be aware that changes are not, they need to be checked. So 3 of the 6 most common causes of cancer death are in the GI tract. So again, keep your weight at a good place. If you eat low fruits and veggies, then you're at higher risk. If you don't exercise, you're at higher risk. If you smoke, you're at higher risk. And if you drink alcohol, you're at high risk. And that list on the right of risk factors goes for everything we've just discussed today. So the entire GI tract is 100% affected by your diet and exercise and the things you put in your body. This is many more diseases that we could possibly discuss, but we're not going to. So if I did not hit on your favorite GI disease, I apologize. But if anybody has any questions, I'm happy to take some. Y'all are a smart bunch.
Talk about pancreas.
Yes, sir. Pancreatic cancer. The pancreas is a really important organ. It sits right under the stomach. There's a good picture. It kind of hides behind the stomach, and so if you get a CAT scan, you'll get a lot of reads that say the pancreas is not well visualized. It's behind the stomach. It's really hard to see. And it's actually, you cannot live without your pancreas. You have to have it. You have to have some of it. It's responsible for diabetes. It's for the insulin. The beta cells that are involved in the pancreas actually help keep our glucose levels regulated. So a lot of type 1 diabetics have a poor working pancreas. Does not mean they are, and then the type 2 diabetics, it starts to wear down. It kind of just fizzles out a little bit as they get older. And so we have to help it. So the pancreas, I'm not sure. I would be remiss if I gave you any facts about why it's getting so high in numbers. I don't really know. Or if I don't know if they're just catching it earlier or if we're just figuring out how to catch it. I don't know. But you cannot live without your pancreas. So with pancreatic cancer, by the time we get it, it's already got a mass. We've got to go in and cut it out. The survival rates are not great. People have survived and know people who have survived. They're not great, but the pancreas is an important little organ, much like the liver. So the reason why they are more detrimental is because you can't live without them. You just can't. So you can live without part of your colon. You get colon cancer, and fortunately we're able to go in and really take out that cancer and hopefully take it all out. You can live without part of your stomach. So most of your organs you can live without, but the liver and the pancreas are difficult, and so they really are affected greatly when cancer occurs in them. And honestly, avoiding alcohol and a healthy diet are the only things that we know. There's a few others, but to keep us or reduce our risk, we just are not sure. It's a conundrum still, an unfortunate one.
Is there a genetic component?
There are genetic components to most cancers. Not always to the GI. I mean, there is to colon cancer for sure. If you had a first-degree relative with colon cancer, if your parents had it, your brother or sister had it, you need to get checked. You need to get checked years before at the age that they got it. We start at 50 now because that's typically when cancers hit, 50s and 60s. But if you had a brother or a parent who had it in their 40s, you need to get checked in your 30s. So we want to catch it early and fast, and even just tiny little pieces we can catch with colon cancer. So there's genetic components to most of the GI tract cancers, but not all of them. You can't always say because somebody had pancreatic cancer, you're at a higher risk. You can't always say that. Y'all have been educated. See your doctors.